There we go. We're ready. It took me a while. Okay, so hi everyone, I'm Emily and welcome to the Tuesday Health Talk, where you'll learn about why bone health matters and how with the right screening, exercise and nutrition, you can feel empowered to prevent or reduce the effects of living with osteoporosis. I'm a registered nurse and specialist coach, and my online business hosts live workouts, such as chair cardio, strength and balance, as well as low impact HIIT for people who want something a bit higher intensity. There is something for everyone, helping those with health considerations to be active, to be connected and be well. Housekeeping, you'll need a pen and paper because we're going to do a quiz quickly, just to kind of aid our learning. And then any questions, you can pop them in the comments box below. If you're watching this on YouTube, then you can subscribe to my channel. I'll be posting these monthly talks it'll be on the last Tuesday of every month. So I would just like to stress that the topics we discussed today are educational purposes only and do not replace proper medical discussions with your healthcare professional. And if you want to make any changes off the back of this presentation, then you should discuss that with your GP nurse or your pharmacist or physio, you know, where appropriate. Okay, right, let's get started. So with your pen and paper, I'd like you just to put 1 to 10 and then just pop your answers in those. We will recap these at the end, but hopefully you'll spot the answers as we go along, and I'll try and help you pick those out as we go along. So how many red blood cells does your bone marrow produce every second? A, 300,000 to 400,000, B, 500,000 to 1 million, or C, 2 to 3 million. How long does it take your body to turn over a completely new skeleton? Is that 8, 10 or 20 years? And what age do you reach peak bone mineral density? So our peak bone mass, sometimes referred to, 25 years, 35 years or 50 years. Question number 4, how many people in the UK present with a fragility fracture each year? So fragility fracture is when someone falls from standing height and breaks a bone. That's not, you know, we're not supposed to break bones from that height. So that's what we call a fragility fracture. So that's 100,000 a year, 150,000 a year or 300,000 a year. Question 5, 50% of people who sustain a fragility fracture will need a walking aid. True or false? Osteoporosis is a normal part of aging. True or false? Number 7, HRT can be an effective treatment for osteoporosis. True or false? Protein is an essential nutrient for bone health. True or false? Swimming is an ideal exercise for maintaining healthy bones. True or false? And exercise is unsafe for people with osteoporosis. True or false? So I'll just leave that there for another minute. I'll just pop a little timer there, look. You are welcome to fast forward this if you have completed those, if you've answered them all, but I'll just leave it there. Promise I won't do the countdown music. All right. Lovely. Right, let's move on. So why do we have a skeleton? Well, to help us move, you know, which is kind of an easy one really. It's to help us move, and it acts as a framework for our muscles and our tendons and our ligaments, and without a skeleton we would collapse in a heap. it offers us protection. So our skull and our rib cage protect important organs such as our brain, our heart, our lungs, and our major blood vessels as well. Blood production as well. So our red bone marrow is the part in the center of our bones, and this produces 2 to 3 million red blood cells every second, which obviously helps us to carry oxygen around our body, and it also produces other cells which are integral to fight infection. And finally, mineral storage. So our bones are our main storage site for calcium. I think about 99% of our calcium is stored in our bones, and the rest we just have sort of circulating around, which we need to keep our bones and teeth strong, as well as for muscle contraction and for nerve impulses that, you know, keep our heart pumping and our legs moving. So they do play a massive role in the kind of health of our body in general. So what is the first word that pops into your mind when you hear the term bone health? So just think about that for a moment. So it won't take long because it's obviously the first thing that pops into your mind. So you might have said milk, or, you know, calcium or strong. I've popped a few other things in there because I think, you know, these things we can discuss throughout the presentation. But I think it's really interesting. I know when I did this presentation live, a lot of people said milk or cheese was one of them, and for good reason. You know, milk and cheese are a good source of calcium, and I don't know about you, I remember always being told as a child you must eat your fromage frais or milk to get strong bones. And actually our bone mass that we attain in our childhood and adolescence is an important factor in the long-term health and strength of our bones. So we build the densest and strongest bones we're ever going to build in our childhood, and we continue doing that until we're 25. So like a savings account, we build up all our levels of bone density, and then with lifestyle factors, you know, we maintain that once we get to about to our 40s, and then we kind of maintain our bone density, and then it starts to tail off as we age from that point. So obviously a healthy diet and a good intake of calcium and vitamin D, as well as impact exercises in childhood, is really important to just ensure that we get as much bone density as possible before we start to lose it. Just going to talk a little bit about you know, what actually occurs in our bones to kind of keep them strong. In order for our bones to stay strong, bones are constantly being broken down and built back up again. This is known as remodeling, and your body remodels a new skeleton every 10 years. The cells involved in bone formation are called osteoblasts, and they build our bone. And then we've got osteoclasts, which break down our bone. And during childhood, much more bone is deposited than withdrawn. So you can see in this graph over here, you know, from early childhood leading up to that sort of mid to late 20s, when we reach our peak bone mass, that depositing of bone is much higher than the rate in which we would, you know, we break down bone. And then as we get over that kind of maintenance curve, where it's generally the breakdown and the build-up is about the same, but then as we tip over, the rate of breaking down our bone accelerates, and it's much quicker for women, as you can see. And the reason for this is that women go through the menopause, and estrogen plays a significant role in our bone. And actually women that go through the menopause after they've had their last period, you know, they can lose around 20% of their bone mineral density in the 5 to 7 years after their last period. So women are at a higher risk of developing osteoporosis. So, so for those women that go through the menopause early, so around their 40s, bearing in mind the average age is about 51, you know, it would be beneficial to discuss that with your GP, because HRT is an effective drug at preventing osteoporosis, particularly in those people that go through the menopause early. It is quite a controversial subject, HRT, and it's kind of not something I can really discuss in this presentation. It's kind of a presentation of its own, really, menopause and HRT. So, but by all means, you can ask any questions at the end. So because of the wonderful menopause, women are more likely to have osteoporosis than men. Although men are still at risk, they just develop it much later in life. So you can see they have a slow progression, and that's generally around 70. In fact, their lifetime risk of suffering a osteoporotic fracture is the same as developing prostate cancer, so about 30%. So what is osteoporosis, and who is more at risk of developing it? So we've already discussed, you know, men and women and the differences. And osteoporosis is causes bone to become less dense and more prone to fractures. And our bones are like honeycomb, and the spaces in this structure grow larger, and the bones that form the honeycomb get smaller. So, and on top of this, the outer shell of the bone also gets thinner. So all of this makes your bones weaker. So what are the risk factors? So starting from the top, so genetics plays a huge part because osteoporosis is hereditary. If one of your parents breaks a hip, then you are more likely to break a bone too. So I think, you know, thinking about family history of bone fractures, but unfortunately, if parents die young, then you probably won't know because they wouldn't have got to the point at which it had been a problem. So it's just bearing in mind what your family history is. Certain medications, so steroids, the steroids that people use for, you know, asthma, COPD, any inflammatory illnesses, so not the ones that the gym buffs use. We're talking about corticoid steroids. And these are, and the link to osteoporosis is only linked to the tablet form. And for people that take the prednisolone of more than 5 milligrams for more than 3 months are at a highest risk. So I should just point out that you know, if you're thinking, oh, you know, I take regular steroids, and, you know, but please don't stop them. You know, it's quite dangerous to stop steroids quite suddenly, and you should always do that under the supervision of your healthcare professional. And next up, we've got anti-epileptic drugs. So phenytoin can reduce calcium absorption. Depo-Provera, so the contraceptive injection, is known to reduce bone density. So the risk of osteoporosis after 2 years or more of the continuous use of the injection. So once you've got to 2 years, it's probably worth having a discussion with your practice nurse about you know, an alternative contraceptive. PPIs, so are proton pump inhibitors, but antacids. They are like lansoprazole or omeprazole, and studies have shown that an increased risk of fractures in the elderly on high doses long term. So you should look to reduce to lowest effective dose, and then, but obviously do this under the supervision of your GP. It may be that you do need to have that higher dose for other reasons, and that's a higher risk to you. So it's worth having that discussion. So good to have your medication reviews. Thyroid medication, so for people taking medication for their thyroid, it's important to get levels checked regularly, usually annually, once you're stable, and that's just to minimise the risk of osteoporosis. And obviously chemotherapy drugs, any of the drugs that we use long term, post sort of the initial treatment for cancers, can cause osteoporosis as well. Rheumatoid arthritis, so chronic inflammation in the joints can cause bone loss, sort of localized to the joint and the surrounding bone. Having a low BMI, so being of low body weight, can lead to loss of periods and hormone dysregulation, as well as not, having the right nutrients to build bone as well. Which leads me on to malabsorption. So, due to diseases like celiac or irritable bowel syndrome, people have difficulty absorbing those nutrients from their diet. Smoking affects the cells as well that help build our bone, and alcohol as well. So excessive intake interferes with calcium absorption and affects the liver, which plays a vital role in activating our vitamin D. And obviously we need vitamin D to absorb calcium. So what is the impact? So osteoporosis leads to fractures in 9 million people worldwide, and 300,000 of those occur in the UK every year. And this is a massive cost to the healthcare economy, estimated to be about £2.2 billion by 2025. Osteoporotic fragility fractures can cause substantial pain and severe disability, often leading to reduced quality of life. And unfortunately, 1 in 4 people, so 25%, who sustain a hip fracture will die within 1 year. And that's mainly due to the complications post-surgery, and obviously then having a disability. They just don't recover from those fractures. 50% of people go on to use a mobility aid. And, that has a huge implication for people's quality of life. Yes, it's going to aid them to do things, but again, there's, people have a lot of pride in themselves, and, that will be a massive change and a massive adjustment for people. So I think it's, good to have some sensitive conversations about mobility aids and not just sort of say, here you go, and make it, sometimes people think, oh, it's ugly. But yeah, just giving people alternatives is a good way forward, I think. Unfortunately, 25% also get admitted to nursing homes or need long-term care. And this has huge implications on the social care system, as well as the effects on families who have to be their caregivers. So, it is multifaceted. So the chronic pain that people go through post fractures, so that can have a really a big impact on people's quality of life as well, and their ability to perform activities of daily living and maintain their independence. And then once you, if you worry about falling, this can increase your risk of actually having a fall. So yeah, it's really important to address those issues. We're also, kind of thinking about all of these things. We are very concerned with our risk of developing heart disease and cancer, and yet we don't ask, am I going to be mobile when I'm older? Am I going to be independent? And this is very dependent on our bone health. And unfortunately, a lot of diseases that we have generally have an owner. So I remember listening to a good podcast not so long ago, and you can go to your cardiologist for your heart, and you can go to your oncologist for your cancer treatment, but nobody really owns osteoporosis. All of those healthcare professionals, your urologist, your GP, can all treat osteoporosis, but no one really owns it. And so no one really talks about it as much in kind of healthcare sector. So what can we do about it? So, I think this can really apply to yourself. Be your own advocate if you are someone that is at risk of osteoporosis, but also healthcare professionals, nurses, doctors, and personal trainers as well, physios, can all do, help people to implement some of these. So, you know, even for yourself, ask, have you broken any bones? Have you fallen? Have you had prolonged back or unusual back pain? Are you on any medications that could affect your bones? You know, look as well, is there kyphosis? So that's that hunched over appearance that people have, especially people in old age, and that is generally due to the compression fractures in your spine, which reduce the height of your vertebrae. You know, that isn't a normal part of aging. You know, it's okay to have a little bit of height loss as we get older, and that's just due to the discs in between your vertebrae not being as juicy and as plump as they were when we're younger. But if you're having, you know, some people can lose up to sort of 3 inches or more, that's not normal, and that might be a sign that you've had some, you know, potentially had some compression fractures. Your ability to perform a get up and go test. So, you know, are you able to get out of the chair and just get, you know, and just walk off? You know, do you really struggle pushing yourself out and, you know, getting yourself steady and walking along? You know, again, that's, you know, another thing to be aware of. And measure, have you lost your height? So we've already discussed that. And a lot of people can do this with the rib to pelvis distance. So, you know, popping your fingers like this in between the distance between the top of your pelvis and the bottom of your ribs. And I think generally the consensus is that if you if there's like 2 finger whips apart, then that's a you know, a strong indication that there's you know, been some bone changes in your spine. Moving on to FRAX. So this is your fracture risk assessment, and this is an internet-based tool which can be used to calculate your 10-year absolute risk of fracture, and it's easy to complete and should be completed on all women aged over 65 and men over the age of 75. And this can be younger if you have risk factors, as we discussed. So, you know, for someone that's gone through the menopause early, you know, it would be ideally for them to have their FRAX score done. And I think, you know, you can do it as an individual, your nurse can do it. And I think personal trainers and physios can definitely do this. You know, it's really easy to do. I'll pop a link in at the bottom of this video so that you can have a look. You don't have to put the bone density scan, so the Dexa scan, which we'll discuss in a moment. You don't need to put that into the score. Obviously, if you did put it in, it would make it more like slightly more accurate. But again, it's still a good indicator for your risk of osteoporosis, or sorry, apologies, your risk of having a fracture in the next 10 years. So again, after you've had your FRAX score done, again, you might have done it yourself, so it might be worth going to your GP. And depending on your FRAX score, your age and your independent risk factors, your GP may invite you for a Dexa scan. So this is a very non-invasive procedure. It's like having an X-ray, generally done at the top of your thigh, at your neck of at the neck of your femur, and then in your spine. And like I said, and it's very safe. But the bone mineral density results that you get from that Dexa scan, you'll get a T score. That doesn't, it's a good indication of your bone strength, but the results of the bone density scan will not necessarily predict whether you get a fracture. So be mindful of this, because often we think scan tells us the full picture, when unfortunately it doesn't. You know, we use it as a tool to aid our assessment. So all of the other risk factors and the FRAX score, you know, are sometimes all that's needed. So, you know, your GP, depending on your, you know, on your age, might think that actually it's not, you know, there's not much point having the scan. They can start you on treatment or change some of your lifestyle factors, you know, without having to have the scan. depending on the outcome, you might have normal bone density. You might be what's called osteopenic, so you're starting to get that bone loss, but you're not considered osteoporotic. But I think if you're in that osteopenic phase and you've had a fragility fracture, then I think you could safely say that you've got osteoporosis. So you know, so I think again, it's not always black and white. And even if you're in that osteopenic phase, you know, lifestyle factors such as impact exercises and healthy diet, and you know, you can maintain yourself at that point for a significant amount of time, and your GP or nurse might just monitor you. And then obviously, if you know, if things like that don't improve with exercise and making sure you've got, you know, the correct vitamins like calcium and vitamin D, then, and you start to dip, then that might be when your GP prescribes you a biphosphonate. So this helps to prevent the breakdown of bone. But again, it's really important, sort of going back from that, is if your vitamin D and your calcium levels aren't addressed, then these drugs aren't going to work as well. So again, it's really important to think about nutrition, you know, your vitamin status before you know, potentially go onto these drugs. But everyone's individual, and again, that's another conversation to have with your GP. So yeah, so your biphosphonates, you know, these are your drugs like alendronate or zoledronic acid, and they are effective and can significantly reduce the progression of bone changes. However, there are a few rare side effects, which means it's now recommended to take a biphosphonate holiday. So if you're taking it for more than 5 years, it is recommended you stop it, but that would always be done under the supervision of your GP, and there is some evidence to say that that you still get the benefit of the biphosphonate even though you've stopped it for a couple of years afterwards. So I think that's, yeah, something to be mindful of. There are other drugs as well, so monoclonal antibodies, so things like denosumab, people might have heard of. That's often used to prevent bone loss for patients who, you know, have gone through the menopausal women that are like higher risk. Also for people that have got bone cancer, so you know, if the cancer spread to their bones, they're often you know, help to just keep the bones, you know, building bone. And yeah, HRT is again an effective drug, but again, they have to look at your history and your kind of your women's health history as well, because that would dictate whether you can have that or not. And then pain relief. I think pain relief is a really important one, because I think a lot of people who do have fractures or, you know, struggle, you know, don't take adequate pain relief. And I think that's definitely a generational thing. But again, it is really important. But obviously take, you know, the least amount, you know, where possible. So starting with your paracetamol, you know, going up to, you know, your anti-inflammatory ones, if you can have those, make sure you double check. And then, you know, things that are like cocodamol, you know, just to make sure that you can move easily. You know, okay, it's not fixing the problem, but if you can move more easily, then you can maintain your independence much longer if you address your pain. So a healthy, balanced diet is always recommended, and obviously a lot of organisations now, you know, we do recommend a food first approach with, you know, trying to maintain a healthy vitamin balance. And no one nutrient really should be seen in isolation of its benefits. I think, you know, there's a lot to be said for having a diverse range of foods in your diet. You should be meeting most of your vitamin needs with a diverse range of fruits and vegetables, pulses, protein, you know, carbohydrates. I've picked out the main ones we need to consider mainly for this presentation. So calcium. So I've popped a list there of some good calcium products that you can get your calcium intake. It's really good if you think that you're not meeting your calcium intake. So older people and vegetarians or vegans might struggle to get enough calcium in their diet. So you can do, I've popped a link at the bottom there, but I'll pop it in the comment on the description as well, is the Canadian Calcium Calculator. Now, I really liked this one, mainly because I only had to put in 1 day's worth of food, whereas a lot of them recommend that you do like a whole week. And I don't know about you, I don't remember a lot of food that I've eaten in a week. So a nice typical day, and if you find that you have got a shortfall, it's not to say that you need to go out and get like the highest dose of calcium supplement out there. It's actually looking at the shortfall that you have. So I think generally we're looking at around sort of 1,000 milligrams a day, about 700 to 1,000 milligrams a day. So if you can only get 500 milligrams through your diet, obviously increase your dietary intake first for that food first approach. But then anything after that, and you're really struggling to get any additional food in, older people really struggle with food volume. So saying to someone, oh, just eat more, drink more milk and eat more, it's like, I get so full. So, supplementing would be, a good option just to top it up. So, 500 milligrams is getting through your diet, then you would increase that to just have a 500 milligram supplement. Vitamin D, there's some foods there. Again, we don't get a lot of vitamin D from our diet so much, but because it's mainly obtained through sunlight, and obviously where we live isn't that great during the winter months, and you would need to be in the sun for like 30 minutes a day with your head, your neck, your arms and your legs exposed to get enough vitamin D. And obviously it's pretty obvious we can't get that here. If you live anywhere in the world that doesn't get a lot of sunlight in the winter, then supplementation is advised. In this country, it's in the UK, it's October to March with a dose of 400 international units, and that can go up to 800 international units as well for anyone under 50. Anyone over 50, then the recommendation is 800 to 1,000 international units. I've popped protein here because I think this is kind of one that's not discussed too much in regards to in terms of bone health. Our bones are made up of 50% protein, so it's kind of sensible that we should have a good protein intake. And protein is also essential for maintaining muscle strength and the size of our muscles, so which contribute to bone strength that way. So most people do meet their protein requirements in the UK, but older adults, vegetarians, vegans again, are at risk of being protein deficient. If they're not careful or mindful of their diet. For adults, we should be aiming for about 0.75 grams per kilo. So for a 70 kilo person, that's about 52 grams per day. And actually for older adults, surprisingly, we need to aim higher than that. So 1 to 1.2 grams per kilo per day. But this is contraindicated in people with kidney disease. So people with other long-term health conditions, actually need this additional protein just because of all of the additional disease processes they've got on in their body. But like I said, anyone with kidney disease should avoid having too high a protein intake. There is this research actually that I came across in terms of people that have gone into hospital with a hip fracture, and they were supplemented with protein drinks, with multivitamins and things like that in it, and they're really cheap, and this actually reduced their risk of complications post-surgery, and the number of days they spent in hospital. So again, it is a nutrient that needs to be considered. Again, the vitamin D is another one in terms of a lot of stuff going on in the news at the moment. Sorry about that. In terms of us, there's a lot of public health measures out there at the moment for us to take a vitamin D supplement, and that's definitely true in terms of we're spending a lot more time indoors at the moment due to the pandemic. So again, I really strongly suggest anyone to take a vitamin D supplement. Again, the research is a bit not clear really in terms of us actually preventing us from getting or suffering the severe complications of COVID-19. They don't really know if it is the vitamin D deficiency that is causing it, or whether that person that is vitamin D deficient, is it due to their immobility, obesity can cause low vitamin D levels. So again, I think it's just nice to keep it simple, is that we're not spending a lot of time outdoors at the moment, so we're not going to be getting hardly any exposure to the sun. So again, take a vitamin D supplement. Alexa, switch the light on. Right, I hope I haven't switched everyone's Alexas on. This did happen in my practice run. So we need to be, and the reason why I've said this, and you're probably thinking, why she said that? So technology has definitely made our lives easier, and we need to be mindful of this, because technology definitely has its place, and it's been a godsend during the pandemic with online shopping and online banking, and be able to do everything from home. But I feel like there is a real danger that everything is being made too easy for us. We literally don't need to leave a desk or our sofas to do anything nowadays. And with the our Alexas, they I won't say it again. You can switch your light on, you can change your heating, you don't have to go to your boiler, all these little things add up as part of our general physical activity during the day. And there was a lovely story that I heard of a man who wanted to go to the bank, and his daughter was like, no, I'll set you up on online banking, and we can get your shopping in, and you don't even need to go out, Dad, it's fine. And he's like, but I want to go out. It's the only time I get to go and interact with someone, when I go to the bank. And that social aspect, as well as being able to go out and walk in the sunshine, for his mental health and his own physical health as well, and definitely for his bone health. So I think it has its place for people that genuinely can't get out, and but I think for people that can, try not to rely on these things too much, because it will be affecting the amount of time that we are moving. So the picture here is the physical activity guidance for adults and older adults, and the being active recommendations is 150 minutes a week at moderate intensity, or 75 at a higher intensity, and that can be split over 5 days, half an hour each day of sort of walking, cycling, swimming, even taking the stairs at work is included in that, or at home, and then building strength on another 2 days a week. So that's your resistance exercises, strength exercises. So and then also minimizing the amount of sedentary time that you have is really important. So in terms of strength training, I think women should not be afraid of weights. We aren't going to get bulky from doing lots of weight training, and you know, unfortunately, you know, going back to children, you know, I read a really sort of harrowing statistic that globally 81% of adolescents aged 11 to 17 years were insufficiently physically active in 2016, and that obviously was the average, but 85% versus 78% were girls. So, you know, girls are less active and not participating in sports as much as boys. You know, I think that is a cultural thing. I think it's getting better, but at the same time, we should be pushing it more in girls because we are at a higher risk of osteoporosis. So the more we build up that bone in that early years, the better we are when or better prepared we are for when we go through the menopause. So again, that recommendation is 60 minutes of moderate to vigorous intensity activity per day for children and adolescents. So they need to get a lot. So just a quick activity. So can you think of any ways that you can increase your physical activity? So, you know, not the ones that are on here, but could you think of any others? So I'll pop my little timer up there. So I'll give you a minute here quickly. So I think it's worth just writing them down, and then I'll discuss a few that I've got as well. Again, you can fast forward this bit if you're done, you just want to hear me talk. Right, okay, nearly there. And yeah, time is up. Okay. So the so ones that I've got are gardening, doing your own housework. It's not my favourite, I must admit. Standing at a desk is often one that we don't do a lot of, and most desks are not ideal for our posture anyway. Dancing to music, you know, I often just, you know, if I'm just feeling a bit overwhelmed or, you know, or anything, I just stick my favourite song, I just have a good dance in the kitchen, and I feel instantly better afterwards. Sitting on an exercise ball, again, you know, at work, a lot of people that I know who've got back issues often sit on an exercise ball instead of a chair. Instead of making piles of stuff around the house, you know, we all do it. The amount made me think of me piling my stuff up on the stairs, ready to take it upstairs, when I could have just done it there and then and got my steps up the stairs. So I thought that was a good one. And then we have got, yeah, putting things back in their proper place. And then also sex, you know, that is another, you know, just another alternative, I suppose, if that's what you want. Okay, right. So going on to the exercise and physical activity. So exercise and physical activity are slightly different, as we could see from that previous slide. So exercise is something that we do that's a bit more structured, you know, at home, classes, going to the gym, whereas physical activity is that daily movement of us walking, gardening, getting up from the chair, going up the stairs, cycling to work. It's also known as NEAT, so NEAT, so that's our non-exercise activity thermogenesis, the big mouthful. This plays a huge part in us maintaining our weight due to kind of energy balance. So the more we, you know, are active during the day, you know, the more, you know, sort of generally, you know, calories will burn throughout the day. And so if we're eating the same calories as what we're, you know, using up during the day, then we can just maintain our weight. Obviously, it's a little bit more complicated than that, but, you know, generally that is the kind of rule of thumb. In bone health, doing weight-bearing exercises such as walking, running, dancing, and resistant exercises like lifting weights or resistance bands can help to promote new healthy bone tissue. Unfortunately, things like swimming and cycling don't do a lot in terms of our bone health. So those, but they can, don't disregard them. Like, please include them in your weekly part of your exercise routine or activities, because they're really good for our cardiovascular health. And for people that have got joint issues, swimming is just a really nice way for them to just get that relief of not being on their joints all the time. But still do some strength work as well. And that doesn't need to be jumping around. But yeah, the Royal Osteoporosis Society, so again, I'll link them in the bottom as well, because they've been really good resource for anyone that wants to learn even more about osteoporosis. But people without osteoporosis, and most people with osteoporosis, can jump, skip, jog and hop. If you have spinal fractures, or you're unable to do moderate exercise, then 20 minutes of lower impact exercises on most days, but just avoid any excessive bending forwards, just to try and reduce your risk of spinal fractures, so that really excessive flexion in our spine. If you're not physically strong, or you're unable to do regular exercise, just aim to avoid prolonged sitting. So standing up for a few minutes every hour, just do a bit of jigging while you're, out in the kitchen when you're making your cup of tea. It all helps. It all, so I'm a big advocate in terms of, or a big believer in, trying not to make, putting mobility aids in too soon for people, because unfortunately, like reclining chairs, as much as they are really comfortable for when you are sitting for long periods of time, the ones that mechanically get you to standing, again, they are appropriate in some circumstances, but I think sometimes they get put in too early, and then people don't use it and don't actually use their legs to get themselves out of the chair. And I think it's really important to say that, those recommendations might seem way off for a lot of people in terms of the amount of time that they're going to need to be physically active. And the least active individuals, who want to start doing a bit of physical activity, even just doing a little bit, you'll get a huge amount of benefit from just a small increase in your physical activity. So just don't feel disheartened that you're not meeting those requirements yet. All the magic is happening inside already. So, please continue and just do what you can, start small and build up gradually. And that's the safest and best way that you can approach that. And these are all the other lovely benefits of exercise. I also work in exercise medicine at a cancer centre in Bristol, and there's lots of evidence around physical activity in sort of reducing the reoccurrence, and reducing helping people with their symptoms during treatment, and I see that all the time. I see the benefit that it has for our patients. And it also gives you stronger muscles. It's fun, it's engaging, you're using your brain. So, better memory, mental well-being. Obviously, it maintains your bone density. We experience pain less when we're more physically active and we exercise. And then better diabetes control, stronger heart, less breathlessness, and basically the most important thing is to maintain our independence. Any questions? So again, pop those in the comments if you do have them. I just probably thought I'd share a little bit about my business here. So so I try and promote people to be active, be connected and be well. So anyone with a like a limitation or a consideration for their health might, you know, think that exercise is not appropriate for them when actually it is. And I have lots of, I've got a few different classes available to people, which I do live on Zoom. So I've got chair cardio, strength and balance, also do low impact HIIT, and I also do a no jumping boxing session, which has been quite popular actually. And I've just changed my model slightly. So I'm no longer doing personal training. So I'm just doing these classes now, and I'm doing on-demand content on my YouTube channel, which I'm just starting to sort of upload to now. The platform that I use with my website, there is a community page with that one as well, and I've got some Facebook groups that people can join and really share their interests, as well as their hobbies and any advice that they want. But again, that is moderated quite a lot. And health talks as well. So these health talks that I want to do every month, I will be doing them on the last Tuesday of every month. So if you want to learn about a specific condition or topic and how exercise and nutrition can help with that, then please pop that in the comments below. And then just that last little picture there is of my nan. So she about over a year ago, before her knee surgery, was really immobile, really struggled with her mobility. You know, her rheumatoid arthritis was not controlled very well, and since she's had her knee op and done some you know, regular exercise with me, you know, she now walks without any mobility aid. She's, you know, been in the garden, you know, maintaining her allotment, you know, doing everything she was doing back in her 60s and 50s, which is just so lovely to see, and I'm super proud of her for doing that. So yeah, so I just wanted to show a success story, you know, and she does 2 sessions a week. It's not, you know, it's not a lot, 2 half-hour sessions a week, and now she's independent and, you know, is living an enjoyable life. So so yeah, I hope you enjoyed this. I will try and make them a little bit shorter next time. This was my first one, so apologies, I've gone over by about 5 minutes. But I'll, I did remember. Let's go back to our quiz. But you're like, I've done this quiz. So our question 1, that was 2.3 million. So we did cover that. Number 2, we turn over our skeleton every 10 years. And question 3, we meet our peak bone mineral density at 25, late 20s. How many people in the UK have a fracture? That's 300,000. 50% of people who sustain a fragility fracture will need a walking aid. That was true. Osteoporosis is a normal part of aging. That is not true. HRT can be an effective treatment for osteoporosis. True. Protein is an essential nutrient for our bone health. That is also true. Swimming is an ideal exercise for maintaining healthy bones. That is false. And exercise is unsafe for people with osteoporosis. That is also false. So yeah, I hope you enjoyed that, everyone. And yeah, thank you for watching, and take care. Goodbye.